We'll go ahead and get started. Thank you, Mr. Richmond, our ranking member. And we have today with us Congresswoman Herrera Butler from Washington, who is with us on our subcommittee. This subcommittee today is on health and technology. It's the House Committee on Small Business, and the title of our subcommittee hearing today, dealing with health IT, is Not What the Doctor Ordered, Barriers to Health IT for Small Medical Practices. Good morning to everyone. Thank you all for being here. Thank you to our panel. We have two panels today, so I appreciate everyone's input. I call the hearing to order. And again, thank you, witnesses, for being here today, Ms. Trudell and Dr. Mashari. And I would just like to start off by saying that I just truly appreciate your participation. This is a very important issue for our healthcare providers and healthcare across our country. Health information technology is the computerized management of health information. It has the potential to improve healthcare delivery, decrease medical errors, increase clinical and administrative efficiency, and reduce paperwork. Studies have shown that adoption of health IT is becoming more common, but the transition is a slow one. In 2010, the Centers of Disease Control and Prevention found that only 25% of office-based physicians had fully functional electronic health records, or EHR. And 10% had a basic EHR system. Studies have shown that there is a digital divide on health IT between large and small medical practices. A study of Eastern North Carolina confirmed that the existence of the digital divide and found that the smaller medical practices is the less likely to be using the EHR. As a registered nurse and a wife of a surgeon who has health IT, I understand that a modern, efficiency, and well-equipped office is critical to the practice of medicine. Health IT offers promise to all medical professionals. However, financial, legal, and technology barriers prevent many, particularly small practices, from moving forward on EHRs. This issue is critical because almost 60% of office-based physicians work in practice with fewer than 10 doctors. In fact, the small practice is said to be the best indicator of the success of EHRs because it is likely to be the last to widely adopt the technology. Since 2009, many physicians have received Medicare incentive payments for e-prescribing Part D medications. Beginning this year, doctors are eligible for Medicare and Medicaid incentives under a separate program if they demonstrate meaningful use of electronic health records. I am particularly concerned that physicians may not be aware that they must report e-prescribing activity this year to avoid e-prescribing penalties that will begin next year. There are other challenges too. As more personal information is available electronically, patients must feel confident that their medical information is secure and their privacy is protected. Physicians need to be assured that the information that they transfer is not changed or misused. We look forward to hearing from today's witnesses about how these barriers can be addressed. I now yield to our ranking member, Richmond, for his opening statement.
Thank you, Madam Chairwoman. I want to thank our panelists and our guests that are here today to discuss this very important issue, especially as we try across this country very diligently to improve our health outcomes and to make sure that we provide the best medical care that we can do, that we can possibly do, and that means effectively using our information technology to do that. So today's hearing will offer an opportunity to examine ways that we can improve the implementation of health information technology. Health IT has the potential to advance health care quality while reducing costs. But right now, many small health care providers simply can't afford it. We have seen the benefits of recent technology can bring to our daily lives in a variety of ways. It is now time for our healthcare system to catch up with the benefits of health IT. They are numerous and wide-reaching for all sizes of medical practices. Those fortunate enough to have access to this technology already know how it decreases healthcare costs, improves patient safety, and reduces the practice of defensive medicine. These system-wide benefits ultimately lead to an increased access to affordable health care. Since Hurricanes Katrina and Rita, when physicians struggled to provide adequate care because they lacked access to patients' health IT, it has been a key concern for my state, which is Louisiana, and our healthcare industry. I'm proud to say Louisiana has been focused on creating a health information exchange since 2007 and was among the first states to offer incentive payments to Medicaid providers this year. We have made upgrading our health IT infrastructure a priority, and I'm honored to have Dr. Elliott, a solo practitioner from my district, here today to share her experiences. From a business perspective, fully functional electronic health records have the potential to improve a practice's net profit by over $80,000 during a 5-year period. In addition, effective health IT can increase the doctor's time with patients and improve administrative efficiency by reducing paperwork. Such benefits make a clear case as to why health IT is needed to assist small practitioners who strive to provide the best care to their patients. However, right now, there are inadequate incentives for healthcare providers to adopt many of these technologies. With 80% of the nation's patient care delivered by small practices, it is important to understand why most of them do not use health IT. Small practices face a number of unique challenges, including financial barriers and complex regulations, besides upfront costs exceeding $40,000 to implement the technology. Small practices face additional design costs, practice disruption, and a lack of certified products. As a result, a significant gap exists in health IT adoption between large and small practices. I'll insert the whole statement for the record, but I just want to say and commend our chairwoman, Elmers, and add to the audience that I think that this is where Congress works best, when we acknowledge that we know what we know and we know what we don't know. And those things that we don't know, we look to the people who do it on a daily basis and the people who have the on-the-ground expertise. So we look forward to hearing the testimony today, because it will be your testimony, your suggestions, and your input that guides the way that we work towards solving this issue on in a bipartisan way, because the issue is too important not to get it done. It saves lives, reduces cost, and all of those things that I know that we're all committed to doing on both sides of the aisle across every walk of life. So thank you to the chairwoman, and thank you to the panelists.
Thank you, Mr. Richmond, for your comments, and I can't agree more on what you've stated. I now would like to ask Ms. Herrera-Butler for her opening comments.
And I'll keep it brief. I wanted to share a story. I had a young woman in my district in Clark County come and visit with me a month or two ago. And she was there to talk about electronic medical records or personal health records or e-records for hospitals or small practices or solo practices. And her story was compelling. Her father, who was a constituent of mine, would bike every day up and down perfect physical health. He was between 55 and 60, I believe. Tremendous. And he had I don't know if it was a palpitation, he had a problem. They took him to the ER, and she was a nurse. She went with her mom, and she said, "We think there's something here." She said, "I think there's a specific issue here." And they ran the tests, and they waited, and the test came back negative. They said, "You are fine." So they sent him home, and I think it was 2 weeks. It was a short period of time. He had it happen again, and he died. And she was devastated. The family was devastated, and she said about a short period of time after that, she received a call from the hospital that said, "We're so sorry. We lost the paper record." And it actually wasn't negative, and went on to explain it was a problem with the paper. It was a problem with losing the paper. And It's so hard to sit there and have someone, you hear about it, you hear this is partially why we need to upgrade, we need to get there. And here's someone who works in the medical profession, and she was looking at me saying, do everything you can to speed the implementation of electronic medical records for many reasons. I mean, you talked about Katrina. I have in Lewis County in my district, can have severe flooding, which wipes out homes. Floods 8 feet plus of the bottom and up to second-story homes. And when that happens, these are older communities. Their medical records could be, I don't know, their immunizations could be stuffed somewhere in a file. And what happens? We lose patient records, and it is imperative. I served here on the Hill as a health policy aide before elective office, before going home and then coming back here. And this was a bubbling issue, in the last decade. This has been something Washington State has worked towards, a state partnership along with the federal efforts in a very bipartisan way, because we recognize we have to get there. The challenges are costs and implementation. I have a doctor from Southwest Washington who's going to share a little bit about her experience. But the reality is, we're trying to find out what we don't know, to Mr. Richmond's point, and figure out how we can speed this along, because paper is, as someone who represents a timber industry, I like using paper in a lot of areas. Let me put that on the board. But when it comes to this issue, we need to make sure that we are entering the 21st century. So with that, I yield back. Look forward to our testimony.
Thank you. And I'll just start off by little housekeeping. As far as the light system works there, you will have 5 minutes to deliver your testimony. I will be lenient if you go over, because I value so much your input. And the light will start out as green. When you have 1 minute remaining, the light will turn yellow. Finally, it will turn red, and then that basically ends your 5 minute period of time. And I ask you to try to stay to that, but again, we will be lenient today for the purposes of this subcommittee. With that, I would like to introduce our first panelist, Dr. Farzad Mostashari. He is the National Coordinator of Health Information Technology with the U.S. Department of Health and Human Services. Dr. Mostashari became the national coordinator in July 2009. Previously, he served in the New York Department of Health and as Assistant Commissioner for the Primary Care Information Project, where he facilitated the adoption of health information technology by providers in underserved communities. Dr. Mostashari did his graduate training at the Harvard School of Public Health and Yale Medical School, and his internal medicine residency at Massachusetts General Hospital. Thank you so much for being here today, and again, you have 5 minutes.
Good morning, Chairwoman Elmers, Ranking Member Richmond, distinguished members of the subcommittee. I'm Dr. Farzad Mostashari, the National Coordinator for Health Information Technology at the Department of Health and Human Services. Thank you for giving me the opportunity to appear before you today to talk about what the Office of the National Coordinator is doing to support the deployment and meaningful use of electronic health records, especially among smaller physician practices. I know from personal experience both the importance and the challenges of using better information to improve individual and population health, especially in a small practice setting. As the former head of the Primary Care Information Project in New York City, we reached out to practices that served Medicaid patients and signed agreements with providers in small practices, in community health centers, and hospital outpatient departments to establish electronic health record systems. Over half of small practices in the city's 3 most underserved communities eventually signed up with the program. In a little over a year, more than 1,000 providers started live use of EHR systems with a 99% implementation success rate. It was hard. The Office of the National Coordinator's core mission is to improve patient care, improve health outcomes, and make the healthcare system more efficient through the effective use of health IT. Much of ONC's work is aligned in support of the Medicare and Medicaid Meaningful Use EHR incentive programs. These programs, which my colleague from CMS will talk about in more detail, provide financial incentives to eligible providers and hospitals that adopt and use electronic health records in a meaningful way to improve health and healthcare outcomes. This unprecedented public investment does not treat technology as an end to itself. Rather, it will result in concrete progress towards our policy objectives, measurable improvements in health and reduction in cost. I'd be happy to talk about all the ways that ONC is supporting this transformation in healthcare, but in the interest of time today, I'll highlight some of our major initiatives. ONC is at the center of efforts to establish standards for EHR systems and let providers and the public know which EHR systems are meeting these standards. We currently have 6 authorized private sector certification bodies, which have certified more than 700 separate EHR products. This is indicative of the development of innovative EHR products that are less expensive and easier to implement for small practices than ever before. Of note, 60% of the vendors of these systems are small businesses with fewer than 50 employees. Our Regional Extension Center program, inspired by the Agricultural Extension Center program, supports a network of 62 state and local organizations that offer training, information, project management, and technical assistance to providers in order to ease and accelerate the adoption and meaningful use of EHR technology, particularly by primary care providers, small practices, critical access hospitals, and other underserved or under-resourced providers. The Regional Extension Center program has enrolled more than 70,000 providers, 94% of whom are primary care providers, and about half are an individual or consortia of small practices. ONC's Health Information Exchange program is helping build the infrastructure for sending and receiving electronic health information securely across the nation's healthcare system, with a focus of simple but secure technologies that can be used by all providers to improve coordination of care, whether they care for patients in small practices, urban clinics, or rural hospitals. These efforts have sparked a remarkable growth in the health IT industry as a whole, which has led to a strong demand for skilled workers. To address this emerging shortage, ONC has supported 82 community colleges in establishing health IT certificate programs where training can be completed in 6 months or less. So far, over 2,400 students have graduated from the community college programs. Another 4,700 are currently enrolled, and we're on our way towards our target of graduating 10,000 students every year. Many of these graduates will end up helping small practices, who often lack the resources for dedicated IT staff to successfully implement EHR systems. Finally, I want to point out that ONC, along with our partners at CMS, the Office of Civil Rights, and other federal agencies, have taken a number of important steps toward making sure electronic health records remain private and secure. ONC has embedded privacy and security into all of our programs and policies. For example, the standards and certification criteria I spoke about require that EHRs have the capability of encrypting electronic health information, tracking who accesses each record, and limiting user access. Meaningful use requires that providers conduct a security risk assessment and mitigate any risks identified. Our regional extension centers are providing technical assistance on protecting privacy and security, and our new health IT training programs ensure that the future generation of technical workers are well grounded in privacy and security. Health information technology is indeed a critical foundation that supports efforts to modernize and transform our healthcare system. Now is the time to get down to the hard work of implementing and using health IT in a way that leads to better healthcare, that is high quality, safe, coordinated, efficient, effective, and patient-centered. And I'm proud of ONC's role in achieving that goal. Thank you for giving me the opportunity to appear before you today. I look forward to answering any questions you might have.
Thank you, Dr. Mostashari. I'd now like to introduce our second panelist today, Karen Trudell. Ms. Trudell is Acting Director of the Office of eHealth Standards and Services for the Centers of Medicare and Medicaid Services, or CMS, in Baltimore, Maryland. The Office of eHealth Standards and Services Coordinator implementation of the comprehensive eHealth strategy for CMS. Ms. Trudell also has responsibility for enforcement of Health Insurance Portability and Accountability Act, HIPPA, standards or HIPAA, standards, and oversees the areas of personal health records and electronic prescribing. Welcome to you, and you have 5 minutes for your testimony.
Thank you. Chairwoman Elmers, Ranking Member Richmond, and members of the subcommittee. Thank you for the invitation to discuss CMS's implementation of the Electronic Health Record Incentives Program created by the Recovery Act, and specifically the impact of this implementation on small and solo providers. The widespread adoption of certified EHR technology used in a meaningful way is one piece of a broader health information technology infrastructure needed to modernize our nation's healthcare system. As we've worked to implement the EHR incentive program, we have sought to strike a balance between setting program requirements high enough to move providers expeditiously towards this goal, but not so high that providers choose not to participate in this voluntary initiative. The Medicare and Medicaid incentive programs provide incentive payments for eligible professionals and hospitals that demonstrate meaningful use of EHR technology. The Medicaid incentive program also provides incentive payments to providers in their first year of participation if they adopt, implement, and upgrade EHR technology. Eligible professionals can receive up to $44,000 over 5 years from the Medicare program, or up to $63,750 over 6 years through the Medicaid program. The hospital incentive payment for Medicare and Medicaid are calculated with a formula that begins with a base amount of $2 million with an added amount based on the number of discharges. Providers must register to participate in the programs and attest that they have either adopted, implemented, or upgraded certified EHR technology, or that they have meaningfully used that technology during a 90-day reporting period. We recognize that for some providers, particularly small and solo practices, moving to adoption and meaningful use of EHRs is a huge shift from current practice. For that reason, CMS has taken an escalator approach to meaningful use, envisioning 3 separate stages that demand increasingly rigorous requirements. We're currently in the first stage, which focuses on using EHRs to collect clinical data, electronic prescribing, initial steps toward patient engagement, and, as Dr. Mostashari mentioned, ensuring privacy and security of patient information. We originally proposed 25 meaningful use criteria for eligible professionals and 24 for hospitals. The provider community commented that meeting all those criteria would be difficult, and they requested flexibility. We responded by separating the criteria into a core set that all providers must meet, and those are 15 for eligible professionals and 14 for hospitals, and a menu set with providers being able to select 5 of the remaining 10 criteria to implement. Less than a year after publishing the final rule, CMS is already providing incentive payments to providers. Since January 1, 2011, more than 42,600 eligible professionals and hospitals have registered for either the Medicare or the Medicaid EHR incentive program via a web-based application. The same application is used for Medicare providers to attest to their meaningful use of EHRs. States are developing their own attestation mechanisms, and data is exchanged bidirectionally with CMS and the states. Providers were first able to begin to attest to meaningful use beginning April 18th of this year, and 485 providers did so successfully in the first month of the program. The first Medicare payments, totaling $75.9 million, went out to meaningful users on May 19th. CMS has encouraged that states across the country have already shown strong enthusiasm for the EHR incentive program. States began launching their programs in January. 15 states have launched to date, and 2 more are set to come online next week. Further, the majority of states have indicated to us that they will launch by the end of calendar year 2011. And as of May 4th, over $83 million in Medicaid incentive payments have been made. CMS strives to increase awareness and participation in the incentive programs by offering a variety of information and tools that providers can use to learn about and successfully participate in the programs. We use a variety of mechanisms to engage providers, including social media, national provider calls, and webinars. We've developed a special website containing guides that explain the meaningful use requirements, user guides for the web-based system, and many other products. Our strategy focuses on making free, high-quality information available through mechanisms that are accessible to busy providers. The administration has made the adoption and meaningful use of EHR technology a high priority. Our Stage 1 rule lays the groundwork for establishing a robust national health infrastructure that supports the adoption of EHRs and PHRs and will help providers practice safer and more productive medicine. We look forward to working with Congress, our many stakeholder partners, and our colleagues at ONC to ensure that the implementation of the EHR incentive program fosters an expanded use of health information technology, broadens the information exchange infrastructure, and promotes the adoption of electronic health records as intended by Congress. I'm happy to answer any questions you might have. Thank you.
Thank you so much. I'm going to ask a few questions, and then I will yield to Mr. Richmond, our ranking member, and we'll go from there. My first question is for you, Ms. Trudell, the meaningful use. You touched on it in your opening statement. Can you once again reiterate what it is and how it is that physicians and hospitals are adhering to it? Because that's obviously the proof that they have to provide.
I'll walk through some of the core requirements for meaningful use, and I think that will give you a good idea of where we're trying to go with that. A number of the core requirements focus around capturing data in the electronic health record so that it can be used over and over for clinical reasons. Some of those include capturing a list of current and active problems, medication lists, vital signs, allergies, smoking status, demographics. So those are the things that we're capturing in the EHR. Then there are some things that are action-oriented, like computerized provider order entry and electronic prescribing, and, of course, the privacy and security requirements.
What would happen if a physician did not actually what would happen if they weren't able to provide that information to you?
For this first year, and again, this is a voluntary program, the provider can register for the program and then has the entire year through to February of 2012 to report that they have meaningfully used for a 90-day period of their choosing. So they can decide what that period is. They track these requirements, make sure that they've met them, and at that point, they would sign on and say, I'm a meaningful user. If they don't do that in the first year, they can choose to wait until the next year to start out, and it doesn't actually have any effect on the total payment that they could receive.
So there are no penalties assessed basically for in regard to the first year?
Absolutely. The penalties don't take effect until 2015.
2015. And that would not reflect retroactively at all?
No.
Okay. I do want to clarify one thing, and I hope you can do this for me. You mentioned the incentives in Medicare and Medicaid, but you cannot get incentives for both. You basically have to, correct me if I'm wrong, but the physician would have to choose which one he or she would like.
Right. The eligible professionals must select one or the other. Hospitals, on the other hand, including critical access hospitals, can participate in both programs.
Okay, so hospitals can participate in both, but physicians, okay. Thank you. That's great. Dr. Mashari, I have a question about funding that was provided with the American Recovery and Reinvestment Act for HIT. Our records show that $2 billion was provided for this. How has that been utilized, and has all of it been utilized, or is there other monies out there and how are we going to apply that?
Thank you. Yes, the ARA provided for $2 billion for the Office of National Coordinator to help establish the infrastructure that would permit providers to achieve meaningful use of electronic health records, as well as increasing the privacy and security of such systems. We have obligated $1.97 billion of the $2 billion. The largest single chunk goes towards the Regional Extension Center program, some $720 million. To establish those technical assistance and project management facilities for small practices and critical access hospitals and so forth. There's approximately $560 or so million that went to states and state-designated entities for information exchange purposes. we have $265 million that went to beacon communities. These are 17 communities, kind of our crown jewels, and I promise the fact that 4 of you on this panel have beacon communities in your states is completely accidental. We have, and these are really the crown jewels that are showing how information technology can improve.
Oh, so when you say beacon, basically it's kind of your test, your field test.
These are communities that were ahead of the curve. Whether it's in Piedmont, North Carolina, whether it's Crescent City, the Inland Northwest Beacon Community, or Grand Junction, Colorado, which are putting it all together. They have higher rates of electronic health record adoption than other parts of the country. They also have governance mechanisms and leadership to use the technologies, the redesign of physician practices, the performance monitoring and feedback, and really bringing all the tools to bear to show how health information technology and its meaningful use can show demonstrable and near-term impact on cost and quality of health care.
Thank you so much. I yield now to Mr. Richmond, our ranking member.
Thank you. And I'll direct this question actually to both witnesses. And I can only think back to my life and especially my childhood when we talk about motivating me to do one or two things. It was either the carrot or the stick. And in thinking of that, I guess my question would be, for many physicians, Medicare and Medicaid reimbursements are already low. The penalties that could further diminish these payment rates for practices that do not transition to electronic health records. And what I'm afraid of is, especially in Louisiana, where we see more physicians denying to see Medicaid and Medicare patients, and as HHS and CMS examine how these penalties may ultimately affect access to health care.
I would start by pointing out that there are no penalties in the Medicaid program at all. Okay. The payment adjustments are related to the Medicare program solely. However, you make a good point, and I think that the balance in the legislation was that there was a carrot and stick approach, but I would venture to say that when you add the incentive programs together with what ONC has done to help to assist providers, especially small and solo providers, to move toward electronic health record, the carrot's a lot larger than the stick.
And I would add that our goal is to have as few providers, eligible professionals, and hospitals that would incur the payment adjustments as possible. We want to help everybody succeed in this program. We really want and doing everything we can to make it so that we not only have an ambitious program, but one that is achievable, and that we provide the supports and whatever else is needed to help every provider succeed on this track. And I think you do need both the incentives and the penalties to get to this transformation, but you also need the supports around it to help people succeed.
Mr. Richmond, may I yield back? I have a question about the penalties versus the incentives. Is there a time limit on the incentives? I know the penalties start in 2015, but do the incentives continue on, or does that stop at the 2015 time?
For Medicare purposes, the incentives extend for a 5-year period, and they start with a maximum of $18,000 per year per provider, and scaled down to $2,000 per year per provider. For Medicaid, the incentive period goes on for 6 years, and it's front-loaded with a first-year incentive of $21,250.
And the penalties, starting in 2015, does that extend on?
No penalties for the Medicaid side, as I said. And for Medicare, They phase in again with a 1% penalty in 2015, moving to a 2% in 2016, and then between 3 and 5 extending indefinitely after that. That's
So they're
statutory basis.
indefinite
Exactly.
penalties. Okay, thank you, and I thank Mr. Richmond.
And this question would be for Dr. Madashari. And the question is based on the idea, and I want to commend you all for a very open and competitive certification process and market. The concern is whether the delay in accreditation has burdened small providers. And if it's true, especially for those in need of practice-compatible EHRs, did you all consider the potential impact of the delays when developing the certification program?
It was quite a concern. A little bit of background on this. Prior to the passage of high-tech, there was only a single accreditation body, the Certification Commission for Health Information Technology. And the legislation, the high-tech legislation, asked us to take another look at that. And the reason was because there were some who were concerned about having only a single point and not having options or choice and a competitive marketplace around that process. So we were required to take a look at that, and our federal advisory committees recommended to us that we, in fact, change that, and we open it up and have more competition in the accreditation process. There was a risk, however, as you point out, that in this switchover, that there would be a time where we wouldn't have sufficient product certified, or the pipeline for getting products certified could hinder the ability of providers to meet meaningful use. And so we created a temporary program that could go into place quickly and a permanent program. The temporary program indeed went into effect very quickly, and I think we haven't heard much on the way of concerns about the certification program, and that's a good thing because it's working. We have now 6 accredited testing and certification bodies instead of where we had 1. The cost of certification has come down. The speed of certification has gone up. We hear from vendors that the quality of service they're receiving has increased, and we now have more certified products than ever before. So in this case, it was a concern, but I think with the right policies and implementation, we've managed to address that well.
Well, good. And then my last question, and directed at both of you all. Both of you all feel free to answer or not answer. But the last question is just, in today's age with so many concerns with security and privacy, I also sit on Homeland Security, so I am very aware of the fact that every day there are thousands of people that wake up trying to hack into either the .gov world or the .com world, and we have to be concerned about that. And what I'm asking about now are complaints that, especially for small practitioners, that there's little guidance on how to safeguard and ensure HIPAA compliance. And what can we do, what can you all do to help those small practitioners overcome that fear? And after that, I'll yield back, Chairman.
Absolutely, and maybe after that, I speak. My colleague from CMS can also speak about that. Safeguarding privacy and security is a shared responsibility, and the practices, not just in terms of their professional responsibilities, not only in terms of patient expectations, but also under the law, have a responsibility to safeguard the patient information that's been entrusted to them. And the Office of Civil Rights has the ability to investigate any complaints and can levy substantial fines, as they have done against some hospitals and health plans recently. But we need to, as you say, support providers, particularly the smaller practices, in being able to do this. We are working with the Extension Center program to provide that technical assistance, to provide that checklist, that easy to understand, easy to use checklist, some templates and best practices around how to do the appropriate, whether it's physical security, administrative security, clinical security settings, configurations, and so forth, in the small practice setting, and that information is available not only to providers who work with the extension centers, but to any provider. We're also working to make it easier on the technology side through our research and development programs. We have a consortium of academic medical centers who are and research institutions who are working to develop the next generation of technologies to make it the easy thing to do, the secure thing to do, and to make it almost a default, and to bake into the products the ability to encrypt automatically, for example, and to safeguard patient privacy. But as you point out, it's we can remain ever vigilant. This is a daily war where the folks on the other side are constantly looking for new opportunities, new vulnerabilities, and new technologies, and we have to, on our side, be ever vigilant as well.
Great. Well, thank you, Mr. Richmond. And I now yield to Ms. Herrera-Butler for her questions.
I'll make it brief. Thank you, Madam Chair. A couple things you mentioned, Ms. Trudell, that kind of sparked my interest with regard to penalties. Did I understand you right when you were saying that for hospitals versus group practices, there were different? I know they went into effect on different implementation dates, and I know Medicaid is withheld from the penalty side. Did I hear you say that hospitals are exempt? What did, at the very beginning, what did?
No, hospitals and eligible professionals are both subject to the same penalty at the same time.
Okay. And in terms of small group or solo practitioners, I mean, a hospital system is going to have a lot more wherewithal to implement an EHR, period. A small group practitioner or a solo provider in a rural area who's not a critical access hospital, right? I know we've propped that up, is going to have a hard time making this investment, particularly if they are the only family physician or OB in a region. And I've met some of those doctors. How are you taking extra precaution and care and assistance? Because I heard you talk about a lot of the goal is to assist with some of those, and recognizing, especially if you're talking about a family doc, it's an aging population, right? Not very many people are going back into this practice, and that's a whole other issue. But some of them I've met have said, you know what, I can run my practice. I've figured this out. I've got enough problems with med-mal and everything else. Don't bring this my way. How are you overcoming that? And in a non, penalty way?
First, I'd like to talk a little bit about the outreach that we have been doing, which is very much geared toward reaching exactly those kinds of providers. As an example, our 10 regional offices over the past 9 months have conducted over 400 events, more than half of which were either targeted specifically to or included significant quantities of small and rural physicians to try to explain to them what the program is, what the advantages are of it, how to take advantage of it, and what some of the other tools and resources, including the regional extension centers, are available to them, so that at least they have the ability to fully and completely assess the opportunity and make a decision as to whether or not they want to take advantage of it.
What kind of feedback, and this is a question I'll ask of the next panel as well, because they're the docs doing this. What kind of feedback have you had from them? What kind of uptake, positive, negative?
We're actually getting good uptake. We've been doing some trending over the period of the last year, and we are getting a sense that a large percentage, I would say over 70% of the physician practices that we're talking to actually have exhibited some interest and are thinking about it.
So when they have problems, right, with a company that was certified by one of the 6, certification agencies, or what is their recourse? Let
me talk about the supports that we're offering. Dr. Brule was one of the first providers to get their payments for meaningful use last week. And she spoke about working with the Regional Extension Center in Kansas, where she is a family practice and a practitioner in a small practice. And she talked about how when she first saw started adopting the systems and saw the list of requirements, that she was daunted by that, but that the Extension Center helped give her an understanding of what is really behind the meaningful use, practical steps on how to achieve it, help with project management. And she gave one example about saying there was quality measures around colonoscopies, and she thought she was doing a pretty good job with colonoscopies that can be life-saving if they identify cancers early on and they can be removed. And she said when she actually had the information system to look within her data, she was only doing it about 40% of the time. And she was really upset. But then the technology helped her make a list of all the patients, reach out to them, have reminders in the system. Those are all part of meaningful use. And she reported that she wasn't satisfied yet, but things were better. She was at 84% now. Then she said, I would never go back to being on paper. So I think what we have in our favor is that providers, even though the road is hard, providers like Chairwoman Elmer's husband, who has gone through the hard work, would never go back to using paper-based systems. And it is rewarding because it is in line with what they want to do as physicians and nurses.
And really quickly, if they have not just a bump in filling out the paperwork or jumping through the hoop or meeting the quality measure, they have a real substantive problem with the IT provider or do they have recourse?
Yes, the regional extension centers. Let me give the example. Georgia and Massachusetts regional extension centers are working with banks to help their providers get loans for the hardware and software. Very practical, addressing a real need that they have. The Extension Center in LA are doing project management, helping them do every phase of project management of going from implementation to meaningful use, and are working directly with the vendors to identify problems and mitigate them when they have it. Ohio REC has developed a comprehensive needs assessment that goes through and helps the practices identify what are some of the weak points that they need and gaps and barriers, and working with the provider to address any issues before they go live rather than trying to fix things afterwards. So those are all examples of practical ways that the extension centers in all across America are working with the 70,000 providers to help them address any problems they might have and move forward productively.
Thank you. And I now yield to Mr. Altmeyer for his questions.
Thank you. Dr. Mostashari, I represent an area in western Pennsylvania. It has some rural areas. It has some very highly developed healthcare systems, as well as smaller providers like you're talking about today. But what I hear all the time is that the certification process is still very cumbersome, the additional certifying entities that were there. And for folks who have failed certification, if a provider fails certification, does HHS encourage the certifying bodies to share why the certification failed, to recommend improvements that could be made the next time?
The certification process, the way it works is that a vendor of a system, a company that manufactures the software, would go to the accredited testing and certification body, and they would seek certification of their product. So that process, we've heard relatively few complaints about. There is, as I mentioned, more competition in that area that has reduced the costs. It has increased the timeliness and the level of service that the vendors are achieving. And as a result, we now have more products certified by a whole range of vendors than ever before. So providers have now, the healthcare providers who purchase these systems, they don't themselves need to go to get certified for the products. They can purchase the system that has already been certified. There are, particularly for the larger health systems who have self-developed their own systems we have created an opportunity for them in the regulation to get self-certified, to say, I don't want to buy a product that's commercial off the shelf. I want to be self-certified. And for that purpose, we do have a program that would allow them to be self-certified. We haven't heard much in the way of, I mean, the standards they have to meet are the same as the standards that a vendor would have to meet, and it is a rigorous process. They have to show that the products have the same security as a commercially developed product, the same level of interoperability as a commercially developed product, and that can be a challenge. But many of the organizations who have developed their own products are very capable, and we have not heard too much in the way of concerns about that.
And that's where I was going to go, actually. How do you distinguish, how does HHS distinguish between a large, very advanced, on the health IT side, provider that's already spent, in some cases, hundreds of millions of dollars to upgrade their IT, to become compliant, to go through the certification process, and then contrast that with the money that's available, the incentives, the meaningful use regulations, to a much smaller provider, maybe out in a rural area, doesn't have anywhere near the resources, but we all want to go in the same direction. You don't want to end up with a VA DoD circumstance where they're incompatible, they can't communicate with each other. You want to all make sure, especially in a region, but eventually for the country, we have an interoperable IT system. So how do you navigate those two very different situations?
That's exactly right, and I think that's why the certification process is so important, because it says that no matter what system you're using, whether it's self-developed, whether it's the biggest vendor in the country or the smallest vendor in the country, they all have to meet certain requirements around interoperability, that they all have to have the codes that mapped to a same set of codes, so that if I get a piece of information from one vendor to another vendor, it can be understood across the systems, that they can produce the same sort of messages when they're reporting to public health, for example, on the quality measures, producing those. So the certification process really is our most important tool in ensuring the interoperability between vendor systems, large or small.
So you do have an end in mind. You're not just allowing everyone in a sort of a free-for-all manner to come up with their own systems and get certified, but you're saying we're not going to tell you how to do it, we're not going to tell you what direction to go and what is best for you, but in the end, we want to have a system where everybody can communicate with each other.
That's exactly right. We have to balance between allowing innovation to flourish, not over-specifying to say that, you know, the box has to be this big and this wide and this is how it has to look, allowing innovation to flourish, but saying there are some bottom-line outcomes that we're going to hold you to. Can you produce a message, an electronic message for interoperability that is specified exactly thus? Right. Can you meet these functional requirements and ensure that we do have not just a collection of systems that are deployed, but actually systems that can work together to create the bigger public benefit?
Thank you, Madam Chair.
Thank you. I now yield to Mr. Tipton for his questions.
Thank you, Chairwoman Ellers and Ranking Member Richmond, for convening this. Obviously, a very important issue for all of our areas. And Dr. Motashari, I appreciate you bringing up Grand Junction on the western slope of Colorado, and we're seeing that extension actually in terms of the quality healthcare network going down through Montrose, with the idea of extending it throughout the entire western slope of Colorado. I do have a couple of questions here in terms of just having an idea of really where we are at right now. What is the time frame that it takes, weeks, months, to be able to get to the certification for either of you? For a doctor? Do you have any kind of averages?
So for a provider to adopt an electronic health record system, it depends on very much on the product they select and the assistance they have around project management. So there are some vendors who very effectively can get a provider from start to finish in a matter of weeks. There are others who have, particularly for larger systems, much longer lead time planning, implementation, and so forth. design and custom configuration that is needed to take place. Every provider makes a decision for themselves in terms of what's in their best interest. And our hope with the extension centers is to give them the best advice we can, or the extension centers can, about what is right for that provider, that group, that hospital, in terms of the system that they implement. It is a challenging process. I want to make no bones about the transformation of workflows and processes and the difficulties that many practices, particularly smaller practices, will face as they make this difficult transition. But it's a rewarding process, and ultimately will be not only leading to improved patient care and coordinated care, but actually will help those practices succeed financially over the long run.
And if I missed this, I apologize, but how many people how many practices, if you've got an average in terms, have signed up, and out of those, how many are solo practitioners?
I don't have any information about how many are solo practitioners. So far since January, we have had 42,600 healthcare providers register for either the Medicare or the Medicaid program. Almost all of those were physicians. And at this point, we have had our first payment run. Let me kind of tack on to the back of the how long it takes question. Once a provider has gotten to the point where they believe they can meet the meaningful use requirements, they then have a 90-day reporting period during which they must meet all those requirements. As soon as they've done that, they can go online to a web system and attest to that meaningful use, and in a month or so, they will have their incentive payment.
Yeah, this may be a question maybe for the next panel, but if you would like to maybe contribute into it, one of the big complaints that I hear consistently from a lot of our physicians gets down to the coding issue, which Dr. Machashari, you were talking about just a moment ago. When we're talking about like Medicaid, is there kind of a streamlining process between requirements at the state and the federal level? Because that's been a real cost driver. I know, I believe in the state of Colorado, we have a different form than the federal government has, which is additional costs that the doctors actually have to be able to assume.
This has been very foremost in our thoughts through the entire development and standing up of this program, because there are both Medicare and Medicaid incentives, and in the case of hospitals, they can qualify for both. So we've worked very closely with the states to make sure that the requirements for both, the meaningful use requirements, are essentially identical. The web-based system that we use for registration is the same for Medicare and Medicaid. The states will handle their own attestation and payments, but we communicate with the states on an online basis so that we're comparing information and making sure that we have the right providers in the right programs.
And Madam Chairwoman, this may take just a second more if you would allow the answer on it, but one of the other concerns that we have from the patient side is certainly the privacy issues there. Are you comfortable that we're making the strides and then going to have, I think Dr. Machashari had spoken to it being ever vigilant in terms of making sure that we're going to be able to have the patient privacy, which I think has been an obstacle for some physicians as well?
I think that we are making strides, important strides in that direction. Everything from the laws and regulations that were passed through the HITECH Act that increased protections for patient privacy. They gave patients the right to see who has looked in at their information and who their information has been divulged to, which I think is going to serve an important role in providing that assurance to patients. It provides for higher penalties, civil penalties for violations, consistent violations of HIPAA. It extends the range of HIPAA to business associates, that they must follow the same security requirements as the covered entities. There are, as we mentioned, protections that we put in place under the certification program, as well as through meaningful use, that security be assessed and any gaps mitigated. We are working very hard to establish a governance mechanism for health information exchange entities. These are all pieces of this, and I think we will see more and more of an impact on making sure that there's more of a sense of public understanding and public comfort that their information is, if anything, more secure in electronic format than in a paper-based world, where you don't know where your record is oftentimes. Records can be lost, as Ms. Butler recounted, where you don't know who's looked at your record, where there's no way of limiting access to certain parts of the record for example, the front office staff who maybe don't need to know all your diagnoses. So there are important protections, but we need to be ever vigilant, and we need to do everything we can to ensure that we maintain the public trust.
Thank you, sir. Now yield back.
Thank you. And I would just like to say thank you to our first panel for being here today and giving us your very important insight on the adoption of health IT for small medical practices. We will continue to watch all of this, and I want to work with you on helping to reduce the barriers that small medical practices encounter. And I would like to suggest, if you can, in regard to our second panel, if you both have staff here, if one of your staff members could remain, and if you could just identify those individuals to us. And again, thank you so much. We'll now call the second panel to the table. Thank you. Okay, I think we can go ahead and get started. And with that, I would like to say to our panel, thank you very much for coming and sharing your comments and concerns with us in this health IT regard. And I'd like to yield to Ms. Herrera Butler to introduce Dr. Sasha Kramer.
Thank you, Madam Chair. It is my pleasure to introduce Dr. Kramer. Dr. Kramer is a resident of Southwest Washington. She serves Olympia, which is the northern part of my district, on I-5, if anybody wants to know where that is. We are in between Seattle and Portland, but we are neither Seattle or Portland. Serves in Olympia and the surrounding areas in the field of dermatology. After completing a residency at Geisinger Medical Center in Danville, Pennsylvania, Dr. Kramer moved to Olympia in 2005, where she now lives with her husband and 2 sons. In May of 2009, she opened her own practice and has been an asset to our community ever since. Dr. Kramer, thank you very much for coming today, and we look forward to your testimony as we move forward.
Good morning, Madam Chairwoman and distinguished members of the committee, especially Congresswoman Herrera Butler, who represents my hometown of Olympia, as she said, Washington. And my name is Sasha Kramer. I'm a board-certified dermatologist, and I appreciate the opportunity to talk to you today about health information technology and the challenges that are facing physicians surrounding the selection, purchase, and implementation of electronic health records in their practices. So as Ms. Butler mentioned, 2 years ago, I opened my own practice in Olympia, where I currently employ 2 full-time and 1 part-time employee, and I see an average of 125 patients per week, with 40 to 45% of my revenue coming from Medicare and Medicaid. Over 2 years ago, I invested in an EHR system at a total cost of about $41,000. I did receive a $20,000 grant funded through the Washington Health Information Collaborative for Health Information Technology and paid for the remaining $25,000 out of my business cash reserves. As a solo practitioner, I was fully responsible for the research, selection, and implementation process of the EHR vendor and system. Initially, during system implementation, my patient volume was dramatically reduced in order to accommodate the learning of the system by myself and the staff. It did take me about 4 weeks to return back to my normal patient schedule. However, 2 years later, I'm faced with the system where I have to completely reinvest in a new system. Approximately 1.5 years after I implemented my original system, my software vendor was acquired by another company that will not support my current network platform. Now I have no choice but to purchase a new system that will cost approximately $30,000 with $6,000 in annual charges. And aside from the financial investment, I once again have to take time away from my patients to implement and train my entire practice on this new system. Having said this, I fully support the use of health information technology. My practice and patients benefit from HIT in a number of ways, including improved patient safety, increased practice efficiency, and simplified claims processing. While I see these as benefits in my practice, there are significant barriers to full-scale adoption and implementation of HIT, including cost, regulatory barriers, and financial penalties and system integration. According to the American Medical Association, the average cost of an EHR system is estimated to be $30,000 per physician, with an average maintenance cost of between $3,000 and $15,000 per year. This is a significant barrier for a specialty like dermatology, where over 40% of the practitioners are in private practice or solo practitioners, and half are in rural areas. Physicians seeking investment capital are having issues finding a lender willing to provide them with an unsecured loan. Others may attempt to finance their HIT system purchase with the vendor, but small practices like mine have little or no leverage in negotiating the terms and rates because of a limited market share. My practice is a great example of the unpredictable marketplace, as I will have invested over $53,000, which would have been $73,000 if it weren't for the grant, in 2 different systems over just a 3-year time period. In addition, there are regulatory burdens with financial penalties that could hurt the full-scale adoption of HIT. Dermatologists and other providers are struggling with the CMS meaningful use timeline. For early adopters who have a contract with a service provider to meet 2011 and 2012 requirements under Phase 1, there will be a very short window between the release of Phase 2 requirements and the deadline for meeting them in 2013. Furthermore, physicians are facing financial penalties on their annual Medicare billables by 7% of 7% by 2017 if they're not in compliance with the meaningful use criteria, the physician quality reporting system, and e-prescribing. This 7% could be a practice's entire profit margin and could make the difference between a practice staying open and a practice closing. Simply understanding and implementing all of these different programs is extremely difficult and often overwhelming, especially to a small practice. In improving HIT adoption across dermatology, I urge the committee to address 3 issues. Number 1, provide sufficient financial and other resources so solo physicians are able to select and implement HIT systems. Number 2, consider delaying the penalties associated with HIT adoption until such a time as a functional integrational system is in place. Short of that, consider grandfathering in some physicians and exempting them from financial penalties so that they're not pushed into early retirement, which could further exacerbate the physician shortage in this country. And number 3, if penalties are not delayed, provide a safe harbor for those early adopters of HIT to protect them from financial penalties related to the meaningful user requirement. They should not be punished for the failure of their EHR vendor to implement new criteria. In closing, I will absolutely continue to incorporate HIT because I see its benefits to my practice and patients. And I look forward to working with you, and thank you for the opportunity to testify before the committee today.
Thank you, Dr. Kramer. And now I would yield to Ranking Member Richmond, who is going to introduce his witness.
Thank you, Madam Chairwoman. It's now my pleasure and honor to introduce Dr. Denise Elliott, who is from Marrero, Louisiana, or who practices in Marrero, Louisiana. She's a graduate of Loyola University and Barry University of Podiatric Medicine. Dr. Elliott has served as an insurance advisor for the APMA and is a board certified by the American College of Podiatric Surgery. She has over a decade of experience as a medical specialist running her own practice. So with that, I will welcome you, Dr. Elliott, and say that we look forward to hearing from your testimony.
Chairwoman Elmers, Ranking Member Richmond, and members of the subcommittee, I welcome the opportunity to testify before you today on behalf of myself and the American Podiatric Medical Association. I commend the subcommittee for its focus on the vital issue of how the implementation of health information technology and electronic health records under the Medicare program will impact small medical practices. I am Dr. Denise Lee Elliott and a member of the American Podiatric Medical Association and Doctor of Podiatry. Currently, I am a solo practitioner and the owner of the Foot and Ankle Center in Marrero, Louisiana. I know there are members of the subcommittee who are quite familiar and supportive of the podiatric profession, but for those who may not know, today's podiatrists are physicians and surgeons licensed in the state in which they practice podiatric medicine. We are qualified by education and training to diagnose and treat conditions affecting the foot, ankle, and related structures, and provide the majority of foot care services to the Medicare population. Podiatrists receive medical education and training comparable to medical doctors, including 4 years of undergraduate education, 4 years of graduate education at one of 8 accredited podiatric medical colleges, and 2 or 3 years of hospital residency training. Most podiatrists are board certified in podiatric orthopedics and medicine or in surgery. I have been board certified in surgery since 2007. More than 65% of the podiatrists in this country practice in 1 or 2 person groups, usually employing a very small support staff and enjoying modest annual revenues, truly the definition of a small business. We face the same challenges confronted by all small businesses that must compete in marketplaces that do not always provide a level playing field. Podiatry practices and other small businesses can and do compete successfully against large businesses when the terms of that competition are fair. But success becomes difficult when the same demands are made upon large and small businesses with no consideration of the unique pressures placed on the small business. Congress is to be commended for recognizing the potential value of health information technology to improve patient care and produce efficiencies that reduce cost. Chronic diseases such as diabetes, heart disease, and kidney failure have devastating effects on patients. Many of these ailments have significant effects on the lower extremities, and the feet in particular. Inefficiencies abound in the treatment of such diseases that could be alleviated through communication and record sharing between family physicians, cardiologists, nephrologists, vascular surgeons, podiatrists, and others. Giving doctors the ability to access information on the patients they care for in real time has the potential to significantly improve the treatment and the lives of patients. At the same time, such communication and coordination should save the cost of duplicate tests, reduce emergency care and hospitalization admissions, and decrease the practice of defensive medicine. The APMA fully supports this initiative that will help podiatrists provide better care for the patients they serve. However, Congress's requirement that eligible providers implement electronic health care records for Medicare over the next 5 years places an undue financial burden on the majority of podiatrists that are small business owners. And while we are well aware of the incentive program to encourage practitioners, such as myself, to adopt an EMR program, it in no way begins to take into account the great expense that a solo practitioner will incur. I do not have access to the economies of scale that work in favor of larger practices, nor do I have the opportunity to participate in a hospital cost-sharing program. I have not yet implemented an electronic health record system in my office, although I have explored and continue to explore the possibilities. In addition to the cost, I fear the effect it may have on my practice. Typical EMR implementation takes anywhere from 6 to 8 months, and I anticipate that I will not be able to treat the same patient load during that period. To what extent will care be disrupted during the procurement and installation process? How long will it take to convert all my patient records? Will I be able to adapt to an EMR system? Will my staff? How long will it take? And while I certainly understand that an EMR system would benefit patients, will it ultimately benefit my practice? The worst thing that could happen for me and for my patients would be to lose my practice because of the cost of implementing an EMR system that is supposed to help them. It has been daunting to try to figure out where to start with the almost 300 certified programs listed on the ONC Health Information Technology product list. I am affiliated with West Jefferson Medical Center, a large hospital in Marrero, Louisiana, so I decided to initially look at a product that is utilized by this hospital. It seemed logical to me to put a system in my office that would work seamlessly with my hospital system and could potentially simplify my efforts in establishing electronic health records in my practice. But I was astounded at the cost. More than $14,000 in startup costs just for the actual electronic health record software lease. The cost for additional hardware, computers, and servers that I would have to purchase could run an additional $15,000 to $20,000. What do I do about my film x-ray equipment? I haven't yet tallied the cost to purchase a digital x-ray system that would be compatible with an EMR. All of this, I might add, at a time when Medicare is decreasing my reimbursements for radiology services and for physicians. I am also evaluating other EMR options, but am consistently learning that the software purchase, installation, and training costs run approximately $25,000 to $30,000 per system, plus additional per doctor monthly fees of up to $600. In Washington, D.C., this may not seem like a big deal, but it certainly is in Marrero, Louisiana. The current Medicare incentive program offers $18,000 this year or next year if I implement an EMR program and demonstrate meaningful use for 90 consecutive days. But it appears payments in subsequent years will be significantly delayed. At first, $44,000 over 5 years sounded like a great deal of money, but I've learned that it will not begin to cover all the costs incurred over those 5 years to become fully compliant with what is hoped to be a fully certifiable, reliable, and interoperable system. EMR vendors are currently not certified beyond Stage 1 of this 3-stage meaningful use implementation plan. In fact, vendors have only temporary certification of their software programs. What happens if the vendor and product I choose is not certified for all 3 stages? If continuing certification is costly.
Dr. Elliott,
Yes, ma'am.
I'm going to interrupt you there, but I am going to ask the rest of your opening statement will be submitted for the record, and just in the constraints of time. And I apologize for that because you are obviously presenting some very vital information. So thank you.
Thank you.
I now am going to introduce our next guest, Andrew Slavitt. Mr. Slavitt is the Chief Executive Officer of the Optimum Insight, one of the largest health information technology and consulting companies. Welcome, Mr. Slavitt. He has held executive positions with several other healthcare companies. He also worked at McKinsey & Company and Goldman Sachs. Welcome, and you have 5 minutes, and we will be lenient with you as well.
Thank you, Madam Chair, Ranking Member Richmond, members of the subcommittee, for the opportunity to testify today on the barriers faced by small group physicians and single physician professionals in adopting and implementing health information technology. My name is Andy Slavitt. I'm the CEO of Optum Insight, and we're one of the world's largest health information technology companies with about 14,000 people worldwide. And we've worked with thousands of physicians to help them implement health information technology and help them overcome their greatest concerns: cost, uncertainty, and complexity. We've learned a lot about what works. Help doctors make the complex simple, and you will see improvements in productivity and adoption. Resist the urge to support efforts, even tied to financial incentives, that do otherwise by adding complexity. It's not just technology adoption that's at stake. What's at stake is actually the very future of the solo practitioner in this country, where cost, complexity, and uncertainty are driving consolidation into hospitals. So to be adopted, technology must be the means of supporting the physician and the patient in something beneficial to them, and it can. Consider the example of how technology could help reduce unnecessary hospital admissions. A doctor may see 40 or so patients in a day. Data suggests that only a small handful of these patients will drive the majority of costs and potential hospitalizations if not treated. Without technology, every patient looks alike until the doctor walks into the exam room. As the doctor gives out orders for a prescription, lab test, a dietary restriction, those that go unfollowed are more likely to end up with a patient needlessly hospitalized. Without technology to help, doctors don't know who's complying and who isn't until the patient shows up in the hospital. Even then, data suggests that doctors only become aware of this about half the time. And without the technology to trigger a follow-up visit, the chances of a longer stay or a readmission go up. All of these changes require less information technology than is used by an airline reservation clerk. In communities where this sort of technology adoption is occurring, like Grand Junction, Colorado, there is evidence that unnecessary hospitalizations, which cost us $30 billion annually, may be dramatically reduced. So I would urge us to focus on these basic things which simplify a physician's life and add more productive time to their day before we focus on more abstract requirements. So what is it about technology that's creating these barriers? Physicians will point to several issues that have been brought up on this panel already: costs, legal uncertainty, and privacy regulations. But perhaps the greatest barrier is simpler than those. Productivity-enhancing capabilities that I described are not today driving the purchase and design of this technology. Ironically, in a world where cloud computing, mobile technology, and social networking are creating low-cost access to a variety of capabilities for individuals and small businesses, the typical physician may tell you that the technology in their office or hospital has often become a contributor to regulatory burdens they face. Whether meaningful use standards are right or wrong is not the real issue. What is important is that today the end users, doctors and patients, are further away from the actual product design because new product development is focused on satisfying those regulatory hurdles of a payer, CMS, rather than on simple innovations that improve productivity. The HITECH Act created important momentum. Approximately a third of office-based physicians are currently planning to achieve meaningful use of EHRs and apply for incentive payments this year. We need to consider that for the rest of the physician practices, the smaller ones, the temporary financial incentives will not be enough to compensate for productivity losses. And private sector innovation is at work to demonstrate the power of technology where meaningful use is just the starting point. Our company, Optum Insight, offers technology, for example, with no upfront costs or maintenance required, no purchase of servers, automating the coding process for billing and collecting from health plans, and most importantly, is instantly updatable based on the needs of the user right from the cloud. The way the world is going, we believe technology should be free. Services should cost money. Technology is becoming more and more part of the fabric of our lives. Our written testimony offers 5 common-sense recommendations for Congress: align the requirements and regulations placed on physicians in the multitude of programs Congress oversees. Second, continue Federal investments in HIEs, which should be as essential to CMS as MMIS systems, which pay Medicaid claims and administer benefits. Third, reduce uncertainty over the legal environment. Fourth, provide SBA loans, guarantees for small and solo practices and other clinicians not eligible for Medicaid meaningful use incentives. We understand this to be budget neutral. Continue support for the regional extension centers you heard about in the first panel, which are proving to be a strong tool to provide expertise to small practices which lack resources. In conclusion, I applaud this subcommittee for focusing attention on this issue. Physicians who practice in small practices, who were once the cornerstone of health care in most communities, are already an endangered species. In the 10 years prior to 2007, the percentage of visits to physicians who were solo practitioners decreased 21%. The trend has only grown more severe since. Simplifying the environment for these practices and private sector innovation should be the goal, while supporting and improving upon the efforts that got underway with the HITECH Act. Thank you for the opportunity to testify.
Thank you, Mr. Slavitt, for your testimony and your opening statement. And I'm going to introduce Dr. Balmer now, our last witness. Dr. Balmer is a professor of law and technology at North Carolina State University, which I was just there about a week ago. in Raleigh, North Carolina. Dr. Baumer has written extensively on the security and privacy of electronic medical records as well as legal liability in the information age. He received his BA from Ohio University, his JD from University of Miami, and his PhD from the University of Virginia. Welcome, Dr. Baumer, and you have 5 minutes for your testimony, and I will be equally as lenient with you.
There we go. Thank you very much. It's a pleasure to be here. Actually, it's a pleasure and an honor to address the House Subcommittee on Healthcare and Technology with Congresswoman Renee Elmers and Congressman Richmond. I am the head of the Business Management Department at NCSU. I have a PhD in economics and a law degree. I've been a member of the bar for 31 years. And within the field of law and technology, I have examined security and privacy issues. My work has been published in economic, engineering, accounting, and law reviews, but enough bragging. I delivered this speech to my wife, and she said, "Tell them what you're going to talk about, and then get to it." So let me just say that I believe the written statement that I provide outside fills in a lot of the gaps relative to this PowerPoint presentation. However, my recommendations, to get right to the point, are that small healthcare firms should be provided with safe harbors in the form of EHR software that insulates them from suit by the Federal Trade Commission, by private class actions, and by state attorney generals. Secondly, currently there is no private right of action under HIPAA, nor should there be. Third, small healthcare providers should not have to be IT specialists aware of the latest techniques in combating identity thieves. And fourth, a step in the right direction, and I'm gratified to hear this discussion, is certified software under ARRA, which creates, I would hope, a due diligence defense if somehow a cyber break-in occurs. So finally, I would like to point out that removing legal uncertainty, as we have seen, will not result in widespread adoption of EHR unless other obstacles are dealt with, including startup costs and interoperability. However, going back to some of the work that I've done, I've worked with people at Carnegie Mellon, Virginia Tech, Georgia Tech, examining FTC interventions on behalf of citizens, privacy, and security. And the FTC has done a very good job. They are dealing with some very clever people, but what we have found and what we have discussed in the FTC's interventions is that the FTC standards for commercially reasonable security evolves from case to case. And that's because the IT technology continues to evolve. So encryption, people talk about encryption. 40-point encryption is no longer state-of-the-art. It's now up to 130, and it could be higher. So these interventions by the FTC create uncertainty, in my opinion, even among large firms, but certainly small firms are overwhelmed. In 2004, I wrote an article, co-wrote Internet Privacy Law, a comparison between the United States and the European Union. It was apparent to me that EU protection of PII, personally identifying information, is much more extensive and effective than in the U.S. More recently, I co-authored an article, Privacy and Security in the Implementation of Health Information Technology, U.S. and EU Compared. Now, we start with the assumption that there will be significant efficiency gains, but there could be some diminution in the privacy of medical records. Let me just provide you with some overall statistics. In some EU countries, 90% plus of their medical records are electronic. In the United States, it is fewer than 50%. And it's also true that in economic parlance, there are significant and positive network externalities associated with making all electronic medical records electronic, so that there is excuse me, an economic justification for subsidizing startup cost. All right. I know I was supposed to confine my remarks to legal, but these things are interspersed. Let me just jump ahead and point out, for example, that HIPAA has over 15 exceptions in which medical information can be transmitted to third parties without patient consent. In the EU, there are only 3 exceptions, which I'd be glad to go into. Let's cite a couple quotes and then finish up. There was a recent article in November 2010 in the New England Journal of Medicine in which it was stated, the question is whether EHRs will help providers defend against such claims, medical malpractice and medical liability, or leave them more vulnerable. The answer seems to be it will do both. I'm sure that's reassuring to providers. Compliance with FTC and security protection standards necessitates firms to be cognizant of recent FTC actions, which requires firms to possess substantial expertise in IT. And yet, in my opinion, security breaches are inevitable. An article written by my colleague, Professor Faye Cobb-Payton at NCSU, stated
and I keep turning my button off. I'm sorry, Dr. Barmer. I am going to stop you there. Your opening statement will be submitted for the record, and I do appreciate that insight regarding all of the security issues that we are faced with. And I would just further that by saying that you've highlighted an area that I think shows just some of the hurdles and barriers that we're up against, which is that technology keeps building upon itself so quickly, and yet we're putting this on our physicians who are small business owners. And how can our physicians be able to incur that cost and stay up to date with the mandates of meaningful use as those evolve, the dollar signs, and I can speak to this on a personal level in our practice, having had IT for probably going on about 5 years now. Now, in order for us to be compatible with meaningful use, we're going to have to encounter about another $20,000, and that's for the meaningful use as it is applied now, and not considering the possibilities of changes in the future. So thank you, Dr. Balmer. I do have a couple of questions, and then I will be yielding to our ranking member. To Dr. Elliott, I know you have stated that you have not put into place your IT yet because of all of the costs that you know you're going to have to incur. One, being a podiatrist, what is the percentage of Medicare patients that you see? Or in relation to, I mean, I'm just going to, if you could say how many patients you see a week, and of that, if you have an idea of the percentage.
I see an average of 30 to 40 patients a day, 4 days a week.
Mm-hmm.
So 120 to 150 patients, and about 15% is Medicare.
Mm-hmm.
The majority of those Medicare patients are hospital-based patients, the patients with the end-stage renal disease,
Right.
diabetics, that being called for wounds or
Sure.
amputations, things along that line, the more severe type of foot conditions.
So I guess the question is, and of course, I mean, this is completely your opinion. Is it cost effective for you to incur the cost for health IT in relation to the possibility of future penalties? that you may incur. You know, if we're, because as you've seen, as of 2015, it will increase and it will be sustained. Can your practice take on that penalty if you do not implement the IT?
My practice can, because it is a small percentage of my practice. So that 1% then becomes 2% and 3%, but it's only a 15% of my practice. So if I was going to do a cost analysis and I had to outlay all this money, for me it might be a better financial decision not to implement.
Not to implement it at all.
Correct. And my big fear is what my colleague here went through, where you do spend all this money and in the future things change and you have to start over again. I already have 11,000 patients. I have to convert all those records from paper to electronic. Now I have to go with a different company, and I have to convert again. Those are all costs that are involved once you convert from one system to another system, because it's not ready for the second phase, or it has gotten booted out or bought out by a bigger company. So.
There again, the implementation and the changes in the technology world are really affecting us directly, because, you know, how can we comply with these issues? And that is one of our concerns, and I thank you for that. I will now yield to Ranking Member Richmond.
Dr. Elliott, and I know that you didn't get a chance to finish your testimony, but I believe in a portion of your testimony that you didn't get to talk about. You talked about your concerns about meaningful use criteria. So I will ask you, consistent with what you said, that we have heard from providers who are concerned that they won't meet the ambitious definition of meaningful use goals required for stage 1 demonstration. And do you believe widespread adoption can be accomplished within CMS's aggressive timeline? And are there unique challenges to specialists in this area?
I think that most of the systems out there are designed for your primary care physicians. So as far as the specialist, I think it is a little more challenging. I think you have to go with a smaller company that's going to cater to my specialty, which won't necessarily integrate as well with the larger hospitals. Then there's interface fees if you want to try to connect with a smaller company to a larger company. So I think it will be a challenge. I would love to see more efforts being placed on the specialist as far as the software vendors. I think it's possible from a timeline to put this in practice to answer that question.
The other one, and this question would be for Dr. Elliott and Dr. Kramer, and a lot of times, I guess they're not clear instances of where reality and theory just don't meet. And when we talk about the incentive program, and I'm curious, especially for both of you all as small practitioners, where Dr. Elliott, I think you said that you estimate spending $25,000 to $30,000 to implement. You may be reimbursed $18,000, and that's after a 90-day period of demonstrating use. Then 4 to 8 weeks after that. Is that just a reasonable timeline or reasonable expectation to expect a small practitioner to be able to front that money and float all of the necessary bills in and recoup it at the end? And as an end of that question, do you all have the access to capital to, if you don't have the money within your budget? Are there lenders out there willing to lend you that money to get you through that hurdle?
I know the software companies I've looked at, some of them have invested into different loaning programs. So the individual vendors have partnered with banks or loaning institutions. But now you're taking out a loan, you're taking on a business loan, would not be a desirable thing for me as a small business owner. So of course, it would put a kink in your cash flow if you had to outlay all this money and then wait for the time frame for it to come back to you. So
I think it is difficult for many practices Most of the companies do give you a 12-month lease period where you divide the payments over a year, and so that makes it more manageable, but it is still a large amount of money at the beginning, which you basically just, as a small business owner, you're the last person to get paid. So you pay yourself last, you save money, and I mean, I would much rather do that than take out a business loan.
And my last question, what was the decrease in the number of patients you could visit while you went through your installation and your 90-day?
It's very significant because it's not just me who has to learn how to use it, but it's the front desk staff who has to register the patient, get the information in, the nurses have to put the medications, the allergies. So the first week, I saw 1 patient an hour, and I normally see between 4, 6, 7 patients an hour. So that's a huge, not only do you have to front the cash for the system, but it's a big dip in your cash flow for the month or months. Usually it takes approximately 6 to 9 months for a practice to get up and running fully with a system. So it took me about 4 to 6 weeks, but the average, I believe, is 6 to 9 months.
Wow. And
Yeah.
according to my quick math over here, I mean, that's almost a reduction from anywhere of 75% to 85% of the number of patients you can see, which reduces your income 75 to 85% during this time period.
It's huge.
Thank you.
And I'm looking at having to do it all over again, and that's really concerning. And I also mentioned that, you know, a lot of practices, especially in my field, there's a huge wait period to see specialists. I'm booked 5 to 6 months out, and so that just puts me even another month behind.
Thank you so much.
Thank you.
All of you.
Thank you. And I now yield to Ms. Herrera Butler for her questions.
Thank you. And Mr. Richmond kind of asked, what I was thinking is, how long is the recoup time? You know, you not only have, like exactly what you said, I was thinking you have to front the money up front. Makes sense. You have to put the cash down, and then you're not having the same revenue that you had in months
Correct.
previous. So 9 months, how long does it take you to break even? Did you break even up to this point? Now you're having to look at another IT provider.
Yeah, it probably takes, I would say, to increase product. I mean, in my mind, there's no doubt that over the long term it will increase productivity. I mean, I have fewer staff than if I had paper charts. I don't have someone that has to be pulling charts, et cetera. But I think it would probably take several years to turn a profit from it. I mean, I would think 3, 4, 5, 6 years.
So it's a long-term investment.
Yes, it is.
I was disappointed not to have our previous panel here. I didn't know they were going to leave, or I would have asked them to stay, because I think it's incredibly important for them to hear. And I was trying to get at it a little bit, what happens to the small and solo guys who run into a problem like this. You know, there's no real hold harmless, I think, in a contract for you.
Nothing.
Is that anything that, even as you're negotiating with vendors, is that something you can require, or do you need, or are they just going to kind of laugh at that?
Yeah, I asked, you know, the new vendors that I was interviewing, and they said, yes, you know, our company is stable, but what does that really mean?
Yeah. Yeah. Thank you for that. I wanted to also ask Dr. Baumer, I had a physician in my office a few weeks ago, and they were talking to me. You kind of came at the security portion from the cyber attack side of it, and you mentioned MedMal, but in terms of discoverability, I had a physician say, look, once I put all this online, it's discoverable in a MedMal case. What is the case with paper records, and is that something you're hearing? Is it the same?
I don't think that there's a difference between paper records in terms of discoverability and electronic records.
You know what? Part of what he was saying was, so you have this great new metrics, right? For you put the information in, and then the computer can generate. Are you looking at this? Are you looking at this? Are you looking at this? Well, a physician may be looking at certain criteria. It's probably not one of these 1% chance. It's one of these other things. But if the computer brings it up, there's a 1% chance, and you didn't go after it. Is it expanding your liability exposure?
Well, I think that's a very good question. I mean, if the computer puts out 4 or 5 scenarios, do you have a due diligence obligation to investigate each of these? And that problem, however, has been dealt with for some time, that there's kind of recommended treatment, and then physicians reject that and use their own judgment. So I'm not sure that because we have electronic records that that's going to be a new source of liability. But as that New England journal points out, we don't know. And there has not been, hopefully in the long run, but people can't hold their breath in the long run, that we will have a reduction in liability. I think that most of these providers are very concerned about lawsuits from people they don't even know about issues that they're not trained about, namely IT issues, which Mr. Slavic might be able to talk about.
Did you have a thought?
Yeah, I think there is a slight difference, Congressman, and that difference is that in a paper record, it may say that a patient is taking a certain medication. Now, an electronic system may say, because this patient is taking this medication, don't give them this treatment, or there's going to be a bad interaction. And so I think the fear of is that creates a level of liability, invisibility into liability that didn't exist before. So what we obviously need to do is encourage the development of encourage people to learn and improve, and not penalize people for improving, and to self-report and so forth. And that type of environment, I think, will balance the needs and interests of the patient with the, I think, very real concerns of a physician to make sure that they don't get penalized for effectively trying to advance the care they're delivering.
Absolutely. Thank you. Yield back.
Thank you. And I now yield to Mr. Hanna. Mr. Hanna, you're fine. With that, Mr. Slavitt, I did have a couple of questions along the same lines of what we were just discussing. Leaving this open and with the incredible rate of innovation in technology and the changes and all of the concerns that you have brought up, and you did an excellent job of outlining some of the areas that you think that we need to be addressing. With that, I just want to elaborate a little bit more on the cost and the time that it does take for our physician offices to implement this. Many times the software company, the vendor will say, oh, within 3 months you will be up and running and you're going to turn a profit. Realistically, and I know Dr. Kramer, you had outlined 6 to 9 months, and each office is certainly going to be different based on the number of employees that you have that will be working with it, the physician, the time that can be afforded to it. In your opinion, are those costs and time estimates way under, because that was certainly our experience.
Sure. It's a great question, and I think Dr. Kramer's story is really probably one of the most important cautionary tales for what can be avoided. And I think that to the extent that we think of physicians in a large integrated delivery system, in Geisinger, where you've come from, we've got to think of them very differently than small business solo practitioners who are very much consumer professionals all at the same time, and they need to be treated differently. And so, if you think about what companies like Intuit charge for practice software for a small business, for a small physician office where they have 75,000 physicians, it's very small. The training time is easy. It's a very intuitive set of applications. Likewise, I don't think there's a great future in charging individuals $75,000 to install technology in their offices and maintain it. We all know that's not the direction things are going. If you're not happy with Google, you switch to Microsoft, and if you're not happy with Microsoft, you switch to Google. That's the environment that needs to be stimulated out of ONC here. And I think that there is good news, and I think the kind of questions that I think need to be asked when talking to vendors are how updatable can it be delivered through the cloud? Can you provide guarantees that I can reach meaningful use? Can you give me a money-back guarantee on the loan if I don't reach meaningful use? And the competition that's spurred, the good news is that some of the competition that's been spurred are actually driving in that direction. Clearly hasn't gotten out to you, Dr. Kramer, but that's what needs to happen.
Thank you so much. And at that, I will say thank you to our panel. This will conclude this our panel for today. This subcommittee will continue to closely follow and take into account all of your comments and concerns, and I certainly do appreciate your time. We will be sending a letter to CMS on the e-prescribing incentive program proposed rule that is now currently in effect or will be throughout this month. I ask unanimous consent that members have 5 legislative days to submit statements and supporting materials for the record, and I would just like to ask unanimous consent. I have an article here that was just posted in Medscape, Medical News, which basically, and I'll just briefly touch on it, Centers for Medicare and Medicaid Services, CMS, is proposing more exceptions to an electronic prescribe requirement that could penalize as many as 109,000 physician, nurse practitioners, and other prescribers who do not adopt the technology. The name of the article is E-Prescribing Penalty Could Hit Up to 109,000 Clinicians. With that, I call this meeting adjourned.
Thank you.